Well, good afternoon, everybody. I'm Stephen Patrick. I'm the Chair of Health Policy and Management here at Rollins School of Public Health at Emory University. Thank you for joining us today for today's HPM Scholars and Policy Practice Forum. We're going to be focusing on a critically important and timely issue. What do current funding cuts mean for state and local health departments, and how agencies can adapt for the moment? I want to mention too that you can also follow our work both on Instagram, LinkedIn, and sign up for our newsletter. We're going to be putting that information in the chat for you to find. So we'll be doing more of these and certainly would love your engagement in the department too. This session is part of our HPM Scholars Program, which is a new initiative that brings former federal, state, and local public health leaders to our department to teach, mentor, and engage with our students and our faculty. This program includes the Policy and Practice Forum series that we started a bit ago. We had one about a month ago focused on maternal child health. We're also doing table talks, which are designed for real world leaders to talk to our students and have conversations. It's really a critical way that we help prepare our students, who are the future leaders in public health, to connect and engage. I'll just note that we have about 1,000 students here at Rollins and about 150 in our department alone. We're really fortunate today to be guided by a truly exceptional moderator, Dr. Karen Hacker. Karen brings deep national and public health leadership experiences. She previously served as director of CDC's National Center on Chronic Disease Prevention and Health Promotion, overseeing 9 divisions, a $1.4 billion budget, and national initiatives in chronic disease prevention, maternal mortality, tobacco control, and the COVID-19 response. Before joining CDC, she led the Allegheny County Health Department, where she advanced efforts on the opioid crisis, improved air quality, and launched the Live Well Allegheny initiative. Throughout her career, she's been known for pairing strategic vision with practical and community-focused solutions. We've certainly seen that here at Rollins. She's widely published and an expert in community-based participatory research. And now we're fortunate enough that she serves not just as an adjunct professor in our department, but also our inaugural policy fellow in residence here at Rollins. So please join me in welcoming Karen Hacker. Karen, I'll turn it over to you to introduce the panel.
Thank you so much for that lovely introduction, Stephen, and it's great to be here today. So I'm going to start with a little bit of an overview and then ask the panelists to introduce themselves. I do want to just mention that unfortunately, Chrissy Giuliano from Big Cities Health Coalition unfortunately is ill today and was not able to join us. So I am very hopeful that some of our other panelists will be able to pinch hit for her. It has been a challenging time for public health, certainly at all levels of government. The events at our next door neighbors here at CDC have just raised enormous numbers of questions about the future, about the money, about surveillance and programs, and possible reorganization. We wrote a paper that is with Lori and Susan and Chrissy this summer, before we even knew what the fall and winter would potentially look like, that was really aimed at the field and trying to help state and local health departments figure out the way forward, given some of the activities that we were already seeing. And that paper was still very much on target. So today, we're going to hear from the organizations that represent state and local public health, that is ASTO and NACHO. And again, Lori and Susan will talk a bit more about what those organizations do. And we will then discuss some of the recommendations that were in the papers and hopefully answer some of your questions as well. I think the link to the paper is going to be posted in the chat, should you like to read it. Hopefully you'll find it a good read. All right, so the first thing we're going to do is have the panelists spend a few minutes introducing themselves and giving a little bit of a framework for the organizations that we represent. So I'm going to start with Dr. Susan Kansagra.
Great. Well, thanks so much, Karen. Really appreciate the opportunity to be here. And thanks to Rollins for hosting us today. I wanted to well, actually, let me just start off with a quick introduction. So I'm Susan Kansagra. I'm the Chief Medical Officer for ASTO, which supports state and territorial health departments. I recently joined, it's been about eight or 9 months now. Prior to that, I served with the North Carolina Department of Health and Human Services for 8 years and also the New York City Department of Health. So consider myself both a state and local health department leader at one point in my life. But I'm glad to be here today and really appreciate you all taking the time to hear more about this. I'll start off with just a few overarching framework comments. I did want to spend a minute on the current context, but no more than a minute, because I really want to talk about the opportunities ahead too, which are some of the things, as Karen mentioned, we highlighted in our paper. But just to talk about the current context, we know generally public health right now is in a time and space of contraction. We've seen some contraction of federal funding. Back in March, we had 11 to $12 billion cut to funding that supported state and territorial and local health departments across the country. We know that, going forward, we may see more of this along with some of the cuts that we were seeing in other parts, in other sectors of public work and service. We know that also there is a shrinking of federal government expertise. We're seeing that particularly at the CDC. And then we are seeing, a political divide in how we talk about public health. And just the general lack of trust, not just in government, but in institutions in general. So, that is the context in which we are operating in this moment of time. But what I want to focus on are opportunities for the future. And again, we do outline some of those in the paper. People often talk about innovation in times of, as a luxury, as something you can do when you have time to think about it. But really, it is also a necessity when there are times of change and when times are hard, because that is how we survive. And I will say in public health, we are really good at doing that because we are used to funding coming in and unfortunately funding coming out. There's been cycles of that have happened, as we often know, because public health funding as a whole is sustained in, in a structure, in a grant structure where you get things in 2 or 3 year increments, or you get funding in when there is a crisis or an emergency, and then when there is less attention to that, that goes away. So that boom and bust cycle we know has been something that public health has been used to over time. Of course, we're seeing that now at a much greater level, but we should appreciate that resiliency that we as public health have had over a long period of time. The other opportunity that I see in this space, and again, we can go into more details, is a lot of the conversation has been around, how do we support some of the gaps that we were seeing in public health? And I do think there is an opportunity to talk not just about gaps, but really if we're going to eventually, and if there's opportunities in the future to build back, and again, I think that's hard to do in the way that we have seen public health, but if we do have the opportunity to do that, and there are a few things coming down, for example, rural health transformation grant and other funds, how do we build back in a way that's better, not just trying to fill in gaps and things that have been lost, but really think innovatively and offer different solutions for the future that maybe would have been opportunities for us, but now this is creating the impetus to think about that. And then lastly, partnering in new ways. And we're seeing that certainly state and local level partnerships together between states in new ways and certainly across sectors as well. And that is an opportunity going forward. So none of this, of course, makes up for some of the loss and change that we are seeing, but they are small opportunities for us to continue to, think about and plan for into the future. So with that, I will stop there for my introductory comments. And again, look forward to the conversation.
Thanks so much. Can I turn now to Lori Freeman?
Well, good afternoon, everybody. It's great to be with you all. I am Lori Freeman, and I'm the CEO of the National Association of County and City Health Officials. And our organization represents the over 3,300 county and city health departments of the country. And we are part of our national system of public health in the country. So I will, I want to give you lots of reason for optimism and hope, because you are in this work force or you're attempting to join it. But let's be real at the same time and start out with maybe the lay of the land and what's going on. I will say, the worry well is alive and well and rampant in public health in terms of our looking for continued threats to the ways and how we do our work on the ground. In terms of impact, I'll repeat some of what Susan said in terms of impact. We saw an immediate, swift, and impactful and almost universal impact in March with the rescission of COVID dollars, that $11.4 billion, hit our local health department swiftly because it was money that was in the field, and it was deploying staff in the field. It was paying for public health associates, the young CDC professionals that are entering the field. It was used to mobilize clinics in neighborhoods and pay for public health nurses and health educators and community health workers. The money was a direct hit to epidemiologists, laboratory capacity, also during a time when we were in an active measles response. So that was swift and painful for our local health departments. And for them, the pulling back of those resources is dollars, but in public health, dollars are people on the ground doing the work. And so that is who was impacted. Then, simultaneously to that, we have this continuing impact of presidential executive orders that some of which touch on issues of importance to local health departments, and namely our ability to serve everyone in every community equally, and so actively navigating compliance with those administrative orders in this space of executing critical on the ground work in local health departments has been somewhat of a challenge, to say the least. We're also in a space we haven't been before, where our voice is being muted a bit because there's a lot of restriction of funding across the government, tightening of belts, simultaneously squeezing all programs, really, but majority of programs across the federal government, making it harder to advocate for one program like public health that traditionally has been underfunded anyway. And we're watching closely kind of things happening on the ground. There's a fight for local dollars emerging as well, where local health departments have traditionally relied upon to source some of their public health work through property taxes and other assessments. And now, with broader restriction, federal, state to local, the squeeze is happening everywhere, and people are eyeballing sources of funds that have traditionally been intended or used for public health for other purposes. So we'll remain in kind of this fiscal austere environment in this country, and money will continue to be a concern to public health, and it's not going to magically reappear to us, and certainly not over the next years, and maybe not over the next decade. And so we're turning towards, what we need to do, what new tactics we have to deploy on the ground to do the work to keep communities safe and healthy. I want to say just a minute on this topic of sort of the public health system as well, and impacts, because the public health system in our country is a partnership between the federal agencies that do health, and a lot of that is the Centers for Disease Control, obviously, for our state and local health departments, but also through HHS, HRSA, programs there. So that federal partnership extends to the state, and we are, and the money flows from there down to locals. And so we will continue to kind of see, with the shrinking of the federal footprint in public health, our reliance on state and local governments to figure this out and to pick up the slack, if not funding wise, which would be nearly, if not completely impossible, programmatically, which is also very challenging, if not impossible. So those are kind of the environmental factors at play right now. The CDC distributes 80% of its funding directly to state, tribal, local, territorial health departments, and the restructuring of the CDC is concerning in that the structure that we have relied upon to flow those resources and that expertise to state and local health departments is changing. And it's we don't have complete visibility and insight into those changes enough to know how they might impact our public health system. There are some positive signs across the country. You know, we have 3,300 health departments, plus, as I said, 2,600 of them are sitting squarely in red and Republican counties in this country. And they're seeing a lot of support for public health in some of these jurisdictions. In West Virginia, we saw a direct threat recently, a challenge to vaccine exemption policy that would have eroded that state's ability to sustain its status as one of the best vaccinated in the country. And that public health argument held in that state, and they were able to fend off further exemptions from vaccination, and they were able to also fully fund and even exceed their funding goals for public health in that state. And then I'll say that also in some jurisdictions, we've seen an intentional leaning away from the federal government over time. And those jurisdictions are feeling better prepared in this administration for the shrinking government because they've structured their resources differently. And, you know, some of our jurisdictions in this country receive less than 20% of their funding from federal funding resources, while others receive more than 90% of their operating budgets from the federal government. So we have this wide expanse and variety of situations occurring. But many of those who have relied less on federal funding are examples of how you can do that. And do it successfully and maintain the health of your community. So I'm going to just sort of wrap up my comments by saying, you know, there are a lot of other threats that we can talk about, including threats to our immunization work and vaccination status, and the work that's being stood up to address some of those threats and provide guidance. But I think we'll get to some of those questions. But what I really want to leave you with as students is that, you know, we have opportunity here, and we have it with the public to continue to build trust with public health, with our public. You know, as newer professionals coming into the field, you have new and different ways that you grew up in a digital age. You are digital communicators. We need you. We need that skill so desperately right now in public health because we have to orient our communities around the necessity of the work that we do to keep them safe and healthy. And there are opportunities to work with this administration in ways that make sense to advance health in areas that matter to us. And no matter all the other areas of disagreement, we cannot build trust in this country working with 50% of the country at any given time. And that's not how we work in public health either. And so there's much we can do on the communication side to bring those new skills into the workforce to replace the retired people that don't have those same digital expertise. And, you know, this administration, we're finding the ways to understand their vision for health, and the touch points that we can lean into are things that we all should care about. Safe food, free of dyes, and other things are not things that are things that we want to support those things that make sense to keeping our communities healthy, and we want to continue to advocate for some of our traditional and tried and true public health things that we need to manage and hold core in our communities as well, like traditional outbreak response and things along those lines. So there's a lot of opportunity. We're finding the ways, and not everything that we have done in the past has been done well. I think we can all admit that. Even the bureaucracy that sits federally, state, and locally, jurisdictionally creates problems. There are ways that we can become effective and efficient. And sometimes we're forced to do that sooner than we want. And now is one of those times, but there's opportunities for us in this space. And I'll stop there.
Thanks, Lori. So I have my list of areas that I want to talk about, but since you brought up trust, I figured I wanted to at least give Susan an opportunity to sort of comment on the trust building. I know that this has been an area that has been talked about a lot, that public health departments are being told over and over and over again, you have to improve trust with your communities. I do want to just say that I think in general, people working in local public health are very familiar with engaging their communities and really take that very, very seriously in terms of building trust. They show up, they're at a, I'll tell you, I don't think I ever worked as hard as I did then when I was a local public health director, because you have to go to enormous numbers of meetings and meet all these people. But I wanted to give you a chance, Susan, to kind of respond to that before we get into some of the other areas.
Yeah, thanks, Karen. I feel like this is a place where we need help as a field of public health. We have been talking about this for quite some time. Public health, as you say, we are really good at engaging communities, at being on the ground. And I think some of this takes time. It's not going to happen overnight. And this is just part of the process. And I think the idea of listening really hard to communities and what they need and want is part of that process of building trust. And even when that means that what they might be, sharing or concerns are not something that we as public health might be used to addressing or hearing. I also feel like just going, touching on the communication aspect of this, I feel like there is a world where now we are seeing people, um, hear and see things in a bubble that is oftentimes created by not just, the people that are around them, but what they're being exposed to online. And we see, everybody talks about the algorithms, right? The algorithms of what you get. And if you hear things enough times or see things enough times, you tend to believe those things. And so how do we as public health also get smarter about thinking about how we listen hard, but how we also communicate through people that are trusted and are not necessarily public health? How do we have other sectors, people that are not in public health, but understand some of the principles and goals of public health and can talk about it in a different way that perhaps we are not doing, that might help foster some of that trust building and partnership over time? So, no magic answers. I know this is something that we've been talking about for a very long time, but I think there is opportunity for us to, I feel like we get humbled again and again by this conversation. And so, how do we bring in others and think about this broader than just, us in public health, but, needing a broader cadre of people that we learn from, listen from, and then do this in a different way?
Thank you. All right, so I'm going to turn to a question that's already in the chat looking at, and that was something that we did talk about in the paper, but getting a lot of, sort of focus these days is what are the gaps that we're filling? What do we think is going to be missing? And, we've already begun to see coalitions building. We've got a Northeast coalition. We've got the Governors Alliance bringing together multiple states, and we have the West Coast doing some similar things. So I'd love to hear your thoughts on this new sort of process that we're starting to see as we begin to see, I'm calling it 1,000 points of light, because I think that once you shift what's happening at the central level of government, then the question is, who else is getting involved, the non-governmental players? And I'd love to hear your thoughts on that. So whoever wants to start first.
Susan, I don't know if you have that. I can
Yeah.
jump in.
Okay. Go ahead. Yeah.
The groups that are being stood up, I was recently reviewing their purpose, why they were stood up, what their goals are, myself, because there's a plethora of them. And, I wanted to kind of get clear in my mind what was being covered by each one. And each of them is slightly different. And I think all of them obviously are super well intentioned, and some of them are already advancing really excellent work in the space of lacking guidance and other data informed work being done betterly. But I really want to draw a line to, between this idea that, we might be able to kind of stand up these mechanisms here and there that help address the gaps. But we're still, let's get straight. We cannot be without some level of federal governmental presence in our work to help with our coordination across jurisdictions. And even with the Western Alliance, the Northeastern public health collaboration, the governors, they all represent different parts of the country, and they're going to be, we're setting ourselves up for an inequitable treatment of how to kind of move ourselves to protect what we care most about, because there will be states that are left out, not able to join or not have anything in their area. And what are we going to do about that? So I have an equal amount. I'm excited about the work, but I have some equal worries that there won't be a way to bring these different groups together to actively cover the landscape of our country in a way that a federalized presence would have. Even if it's a light presence, some coordination is needed.
Before I let you go, Lori, there's a question in the chat that focused specifically on gaps in preparedness. Any comment you would want to make on that?
Now yeah, this one is probably right at the top of my mind in terms of what to worry about, because I think there is a pretty concentrated effort, it seems, to reduce the federal availability of resources and expertise during emergencies. And I worry that, again, we'll take an example. There are many in our past, but the most recent catastrophic one was the hurricane that came up the East Coast that hit, successive states up the East Coast of the country, landed in North Carolina mountains, caused devastating results. The federal government, was instrumental, because that hurricane landed in Florida and went the whole way up our country and had, different results in different parts of the country, some in areas that were completely unprepared, unexpected. And without, think about what that might have looked like if there wasn't a federal preparedness response to that, a FEMA response, an ASPR, name the federal response. But if you don't have a coordination level there, the states will be woefully, I think, unprepared. And Susan can comment on this, to try to do this themselves in the height of a true emergency that's taking a lot of resources all at once and with some urgency.
Yeah, I'll just chime in. I think on two things, maybe just going back to that first question around data in surveillance as well. I think a perfect example of this was actually what recently happened during the shutdown, where you saw that the respiratory virus tracking dashboards that CDC had went down, and they were not updated for a few weeks. And actually, I was meaning to check today to see if they were back up, but they hadn't been up for a few weeks. And we lost the national picture of what was happening around RSV, what was happening around COVID, influenza. Luckily, the states had their dashboards up. They were tracking, thanks to, again, some of that federal funding they were receiving, though they've lost a lot of that money that many states were still tracking. But so a picture was cobbled together, and there was a lot of others that kind of tried to look at each state's board and try to put together the complete picture. But it wasn't the same as having a national outlook and a national surveillance system and creating that. So, there is a loss, and it'll be interesting to see where some of these surveillance systems move going forward. I think about the ones that were, especially in your area, Karen, our chronic disease behavioral health surveillance systems, and what will happen to those going forward. And are there other mechanisms to know at a national level what our youth smoking rates, youth vaping rates, what's happening with diabetes rates, right? All of those things were captured through some of these national surveillance systems. And there might be, innovations that we can and should be thinking about going forward and how to do that in a different way. But that's, it will be different than what we've had for sure. And then going back to preparedness, this is something that worries me. I know is something top of mind for states, as you mentioned, Lori, for local partners as well, because we know a lot of the funding to support preparedness has been federal dollars that come down to states, both via CDC and public health preparedness, but also, of course, via FEMA and other agencies like ASPR as well to do hospital preparedness with our healthcare systems. And so adequate resources in a state are highly, highly dependent on federal resources coming down. And there has been that shift to kind of transition more to a state. So, I think that is a concern around resources that will then be available at a state level. And, there's many things for which you need, national expertise, right? Not every state needs to have, an Ebola expert in their state, but having some of that national expertise that can be shared is I think, a very efficient use of government resources rather than having to create that 50 plus times over again across states or local territories. I'll pause there. I think I had one other. Oh, yeah, actually, one other thought I'll just mention. We talked about the state sharing and some of the collaborations that have happened, and Lori, appropriately mentioned, right, some of these collaborations that have been announced have been more blue state collaborations. I will say, there are other collaborations that perhaps are not, announced, but that we are seeing state to state sharing across blue and red. And I will say, being in North Carolina and experiencing, the thing that you mentioned, Lori, around Helene, but certainly hurricanes in general, we had a collaboration with South Carolina around sharing lab capacity in the event that a hurricane happened and impacted our public health labs. So I think that type of creative sharing across states, we will see more of that going forward.
Thank you. So there was just one other question on this topic area, not that there aren't many others, that really had to do with the data. I guess I'll start only because there seem to be questions about particular data sets that were in the center that I ran. And I think the big issue is that nobody knows. And I think that is to a certain extent, and we know our colleague Chrissy says probably one of the worst parts of this whole thing is the unknown, is the no clarity about the direction or the loss. So it becomes very difficult then to even plan for the future. At this point in time, there is collection of data going on in the field, but in some cases, for example, with the PRAMS data set, the people who were at CDC were actually reduced, and they're all currently on administrative leave due to the lawsuit that was filed. And similarly, there are other data sets that are very much up in the air, the youth risk behavior surveillance system, the behavior risk surveillance system, which may continue, may not continue, may move, but all of those questions really remain unanswered. So in the meantime, we are starting to see efforts by universities, by groups at various different places, sort of pulling together to try to replace some of those data. Would either of you like to comment on filling the surveillance gap?
I can start there and I'll mention, it's nice to see some innovative things. I already mentioned one example of that when the respiratory virus surveillance dashboards came down from CDC. We saw, for example, other partners in other schools, for example, schools of public health putting together a summary of what they saw happening based on state dashboards. There's another tool out of Yale that's looking at EHR data and helping have that EHR data share what is happening in trends, including on respiratory viruses, but also broader than that as well. So I think there are other opportunities and other things that we have been talking about for a long time in public health. Some of these things are not new, but perhaps this is the impetus now for thinking, more strategically about how we use some of these other tools that might become more available to us over time.
Thank you.
And just a necessity. Yeah.
Great. So I'm going to move now to another question that's come up in some of the questions that we collected before, which is really about as resources from the federal government dry up or shift, how are local and state health departments going to diversify their funding? And what does that look like at the local or state level? Laura, you want to start?
Yeah, sure. In the past, we might start to see and say things like, well, let's look at maybe in going back to increasing our services and getting reimbursed for services. But with the changes to Medicaid coverage and the funding of that changing drastically, that is not an area that we can even go to anymore, right? So I think health departments are, returning to some of their core, tenets here, which is if you're to follow Public Health 3.0, you're really looking to be the chief health strategist in your community, and you're organizing among all your partners the work to be done on the ground to address your community health improvement plan and your CHIP-CHA work. And you're not really needing to actually be the direct recipient of funding yourself. You're an orchestrator of this work in the community. And we have a lot of health departments that took that seriously and made that move and actually are hurting or going to hurt less from the reduction in the federal resources. So they're in better positions they're not actually having to do much, or their programs are shifting enough on their own. They can still maintain them just a little bit less here and there. For the ones that rely more, they're looking and seeking funding in other ways, relying more on local sources of revenue, taxes, like I said, property taxes, but that's becoming more challenging because everybody has their eyes on those same pots of dollars. So I think the way the future is going to remain those partnerships, getting the work done through partnerships through other people that have money or can get money, orchestrating that work, being the backbone organization. Also, tapping into local philanthropy where the philanthropists are in the community, they care about the community, there might be a health connection that can be leveraged. And then finally, I'd add, really turning towards some of what should become more and more of our traditional partners, but are non-traditional, which is our healthcare partners, our hospital systems, but are also our federally qualified health centers, our community health centers to leverage the spectrum of prevention to health in the community with those two governmental units coming together. And that's an opportunity as well. And then finally, business, the private, public partnerships opportunities to make business as well, through public health initiatives.
Thanks. So Susan, are you seeing, particularly at the state level, with the shifts that are impending around Medicaid, are you seeing shifts away from public health to support whatever gap states may feel maybe coming down the pipeline? What's your sense?
Yeah, so it's interesting. And I think you're referring to, right, the cuts that are coming down with Medicaid, and how does that interplay? We're seeing cuts on the public health side. How does that interplay together? It's interesting because I still think there are some innovative public health Medicaid partnerships. I do think both areas are under immense strain and certainly will be going forward. The one interesting new piece that is now in the mix is these rural health transformation grant funds. So as folks know, that's $50 billion in funding that is going out to states over the next 5 years, that in many cases, went to the governor's office to, figure out the application. They pulled in public health, pulled in Medicaid, pulled in rural health in their states to come up with what those applications will look like. On one hand, because of those Medicaid changes, states will see a loss of funds. This does not necessarily make up for that, but it's designed to be more transformative than, again, just filling gaps. Really, how do you redesign systems? So I think that is an opportunity for states to think creatively about how they design partnerships, think about systems change. We don't know what's going to come after that. So that systems change has to be something that perhaps there needs to be initial investment for, but maybe is sustainable over a longer time period with less funds, but how to do that and do some of those collaborations using that funding. So I do think that's an opportunity going forward as well. That states will have and should know here soon
Absolutely.
about.
I think that's extremely timely, Susan, since I think those things were due maybe last week or something like that. We should be hearing about funding relatively soon. And I do think that there is a lot of hope for system redesign as a result of these rural dollars. And not all of those dollars are going from states out to the field. So it'll also be, I think, very interesting to see how states themselves decide to use components of that, given some of these other stressors that we're seeing. So you've mentioned, both of you, partnerships. And I think that we call them, whether they're the normal partners or whether they're the not normal partners, the bottom line is I think we're going to need all the partners we can get. And have you seen any unusual partnerships evolving either at the state or local level as a result of the stress that these departments are under?
I don't know if I would characterize any as unusual, but I'll have to think about that a little bit more. But I do think that there is more impetus for partnership. Again, we've talked a little bit about more of the state to state and state to local partnerships that are emerging. And I think some of these partnerships, yes, were in response to things that we're immediately seeing, but a lot of that work is work that would have been great at any point in time, but this is creating more of that impetus for sharing. So, glad to see more of that happening now. I think certainly as we think about public health and telling the story of public health into the future, and again, I'm taking a little bit more of the long view. I feel like there's always a pendulum, and we've seen this pendulum swing back and forth with public health. At some point, we will see that back in the future. And how do we bring along other sectors? And I feel like the business community right now is particularly important. And how do we make public health priorities also sing for the business community as well in a way that, when there is a need to go in and ask for more funds down the line, or when there is a emergency in a community that requires a response, where there's other sectors also saying, hey, funding public health is important so that we can make sure our entire community is healthy and resilient and can bounce back. And, we in our sector find this important too. So I think those collaborations will be important, certainly now, but into the future too, if we want the pendulum eventually to go back.
Thank you. Lori?
It's interesting, when I think about partnerships, I think they're often easier when there's an abundance of money around, floating around. People can say, hey, help me out. I give you, a grant here or there. And when money tightens, people get hungrier. And it sometimes, we saw this during COVID, where partnerships can be impacted. And so we've been down that road during COVID and post-COVID, and we want to come together differently in this moment is what I would say about partnerships, and think differently and newly about our partnerships. I bring up the community health centers. Maybe they always sit beside us in the federal government in a different agency, and viewed very differently, advocated for very differently, funded for very differently than our health departments of the country. And there's a real opportunity for us to really show the value of governmental health here by coming together. And they're suffering in this moment, a little bit less maybe than public health, but they're having to strategize and think anew about their work. And, there's opportunity here for us to think together about how we use new technology, new relationships to help build the argument for governmental health and the support for that, from prevention to health care through our FQHC. So I think we need our partnerships, and we also, can't be in this position of re-engaging and reinventing them every couple years. They have to be in place all the time and ready for us and ready for each other when we need them. And every community-based organization that I know, or a lot of them, are hurting right now. And really, survival isn't really going to be of the fittest. It's going to be probably by coming together and holding each other up, because not one of us can do the work.
Great. Actually, so I have one more question, and then we were going to turn our attention to some of the other questions that are coming in. I've been trying to wrap them into our discussion already. And this one's really about opportunities. First of all, I think there's a lot of questions about the AHA reorganization that's going on, and the impact that that has specifically on chronic disease at CDC, which I certainly know very well. But how does this begin to open opportunities? I think, Lori, you mentioned this a little bit in your opening comments about trying to understand kind of some of the direction, and that there are some areas, I should not say so, I mean, there are many areas where there may be actually agreement. Susan, you just brought up the whole rural health environment, which I think is an area that has long been ignored, honestly, and is now sort of coming to the fray. So can both of you maybe speak a little bit about what you see in terms of opportunities for state and local public health in the years to come? Lori, you want to start with that?
Yeah, I have said this repeatedly, and I'll say it again here, that, whenever you have a situation where an administration is wanting to shrink the federal government or federal footprint, it's actually a unique opportunity for local jurisdictions to maybe leverage the moment to be more powerful, because the control is wanting to be situated state and local. And so the challenge with the argument that I'm making here is that the resources have not followed or may not follow in this moment, but clearly there is an opinion that decisions should rest state and locally. And I think that in public health, we would want to embrace that in many respects, and gain and regain some of the public health authority and positioning that we lost during the pandemic. And then, like I said, there are areas of chronic. We can definitely get on board with the fact that we need to address, the food of the country, make it healthier, remove all of the additives, the dyes. That's a no-brainer for us to actually say 100% we support that. And we have to weave in, find the areas that we can actually come out with and say, yes, we're behind this. And this is how we can help you at the local health department level. This is how we can implement those strategies. And while we're at it, maybe consider why we have to do that is because things on the ground aren't the same for everybody. Weave in our work into the work that they are trying to do, and that is the way forward, at least for the next few years.
Susan?
Yeah, and I can just add on that, and I'll actually drop one link in the chat, which was another blog piece that we had done, the ASO team had done in relation to the first MAHA report that came out. This was before the second one that came out from the MAHA Commission around some of those opportunities. I do think there's intersection here. I feel like this is a Venn diagram of what public health and state, local, territorial health departments have been doing for a long time in chronic disease prevention. There is a new frame, and there's new ideas, and there's a number of things under this MAHA umbrella. And MAHA, when I say that, there's two separate things. There's MAHA Commission, there's a grassroots MAHA movement. Those things are different. But in that, there is a Venn diagram of things that intersect. I think about how for a long time, state and local and territorial health departments worked on food procurement, government food procurement, and how can we make that healthier? Well, we're seeing some swing back to that around thinking about, okay, how do taxpayer dollars support health? At one point we were funded to do a lot of work around, sugary drinks and consuming more water and thinking about sugar consumption. Okay, well, we're seeing some themes there. Are there opportunities there? Certainly, physical activity in the environment. How do we work on built environment that supports more of that? So I do think there's opportunities. I think the challenge, as Lori mentioned, of course, is the funding. What will happen to the funding of that? Will that look differently? Will it ask for different things? Because so much of that work locally is dependent on federal dollars. And so I think that is a question that still remains to be seen. But it's pretty clear that there are some intersections and opportunities in how we talk about the things that we were doing for a very long time and support that. Lastly, I'll just say there's also some new pieces, like we're seeing more emphasis around individual based supports and telemedicine and telehealth and wearables and technology that support chronic disease. That's a little bit different than the traditional public health. That's getting a little bit more into the healthcare space, but again, maybe there's opportunities to think about those healthcare and health systems partnerships to support innovative ways of doing care, whether that's diabetes prevention, care coordination, blood pressure monitoring, again, some of those things that we have been working with health systems on for a long time.
All right, I am now going to turn to some of the other questions that have come in. I think we managed to get a few of them, but one of the questions was actually about the extent of impact to your organizations, because both ASTO and NACCHO have been recipient of federal dollars, particularly from the CDC, and maybe you could talk a little bit about how you are navigating the scenario. Laura, you want to start?
I can, yes. Very carefully navigating. Because we are positioned as an extension really of our CDC partnership with the local health departments. We pass money through to our local health departments to the tune of about $38 million a year. The funding cuts that we have seen, some of them were anticipated because they were COVID investments that were wound down a little earlier than we thought and had some earlier impacts that we had to navigate quickly. And then other impacts have been slower over time, but lesser impactful. And right now we seem to be in a steadier state than perhaps we were 6 months ago. So, but over the course of that time, we definitely saw reductions in our federal granting in areas that were being particularly targeted by this administration as work that did not fit the priorities of this administration. And we saw like the elimination of whole programs, like our HIV program largely has gone away. So we definitely saw impacts everywhere, some more than others, but we are now stabilizing after that period of disruption. Thank you for the question.
It's good to hear that. Susan?
Yeah, I'll add the same. I think we, similar to what states have been experiencing, we have experienced some funding reductions as well. And, in many places where we see states still have funding, we have that funding to support them too in providing TA and resources and all of that. So, certainly where we go into the future, nobody knows. And I think that's something that we are also thinking about. And how do we, as we talk about all these things, partnerships and innovation funding sources, that is a conversation, our team is having as well and supporting states. So yeah, we'll keep an eye on the future. And I think all of these things that are relevant to states are also relevant to organizations that support states.
So there's a question about adapting to the loss of standardization. In other words, a national approach to data programming and what happens. How do we manage to adapt to a scenario? We've talked a lot about how others are jumping into this and helping to some extent, but often on a very regional basis or very local basis. So what are your thoughts about the loss of some level of sort of national accountability, national standardization? Either one? I don't know. Susan, you want to start?
Sure. So I think this is where we are seeing some of that innovation happen. And so there has been a loss of certain types of standardization we were seeing. So, giving an example, a few things we saw, the Advisory Committee for Heritable Newborn Disorders disbanded. That was the committee that helps decide what conditions states in public health laboratories should screen for in newborns, what types of congenital illnesses. Well, okay, are we seeing others start to step into that space? And I think, conversations there. Certainly vaccines. There's other organizations that have stepped in to think about, okay, how do they provide consensus statements and provide additional information there? So I think that is something we will see more of in different organizations, or again, some of that state to state sharing to ensure that there is stability. I can't say that this will ever make up for what we were seeing with the federal expertise and some of that standardization, but there is these pockets of innovations that are happening as a result of that to try to help support national public health, whether that's guidance or again, standard resources, to help create a little bit more of that, you know, fill that where that's missing.
Lori, anything that you want to add to that?
Only that I think the one area that I would be concerned about just taking the biggest hit here is that, we were in an active data modernization effort, with the CDC that it appears to be just I don't know where that is going now. And that was the effort to bring us out of the 18th century or 17th century, try to get us to a better place now. And I think there's just a lot in this space that's worth talking about, because with the onset of new technology and us already being behind, the potential hold on this federal investment to help modernize our data systems, and standardize them a little bit. I'm not sure how much is currently lost other than the individual systems that there were a proliferation of which, right? And we don't really know what we lost there, unless we have a good inventory one by one. And I think too, the ability to stand up a national surveillance system in this space to replace anything is just really going to be challenging. And we'll have to continue to watch this area. And the final thing I will say is, we do have national organizations that are well respected and that are actively willing to come out and openly provide guidance. And those are the medical associations that at least provide a backdrop of additional reference points for our customers, our public people that may not trust the CDC guidance at this point, and maybe we don't want to point people there. I don't know. Today, there's new guidance up on that site that is referencing the links to autism and vaccination, both with each increasing push away from our standard messaging, and the emergence of other national organizations with different messaging. I think we're going to have to rely on multiple sources of truths. And it's not ideal, but it is something that we're facing.
So we're coming to the end, and I had sort of one last question that I thought was particularly relevant, given that you are at a illustrious Emory University. And that question is, what advice do you have for the graduates, the May graduates who are feeling kind of discouraged about the current scenario and the climate?
I'm happy to start off there. We need you. We need your innovative thinking. We need fresh eyes on this, and we need, new energy. So I will say, it's easy to get caught up in the moment, but again, in public health, think about the long view. I feel like any change or any public health intervention that we think of as worthwhile and having impact has been years, if not decades, in the making. And so I think remembering the long view there, and yes, times are hard right now. They will not always be. Yes, we never have enough funding in public health, that's for sure. But, again, that pendulum swings, comes and goes, and, there's always opportunities to make difference. And I feel so fortunate I can be in a profession where there's other people that are facing really hard times, but can't say they're in a profession that gets to have the deep impact to health and to people in the same way that we do. So I think that is something to just really appreciate and to own and think of as a positive glimmer, even when the work is really hard. So we need you. Go into public health. Talk to us if you want, more advice or thoughts.
Thanks, Susan. Lori?
Well, ditto, all great messaging there from Susan. I will just add, if I love this saying. I was always taught it, if you love what you do, you never work a day in your life. And I feel this every day from our local health department leaders, the staff that work in those health departments, the colleagues that I work with nationally, the students like you. You are our future. You have so very much to offer to this field that we need right now. We need your energy. We need your vision. We need your physical self in health departments across this country. We really do. We need your thought leadership. And as one 26-year-old young professional recently approached me 2 weeks ago at APHA after this very session, actually, and said to me, you guys are pretty old. Like, like what? Who's replacing you? And I really appreciate the honesty of a student. And I said, well, it's you. It's you are the generation that is replacing everybody here, and we are happy to help you, to mentor you, and to help nurture you as professionals. So I welcome any one of you to reach out to me directly at any time, and stay with it, because it's the most rewarding work that you'll ever do.
Thank you, Lori. And I want to say thank you to everyone who joined us today. I think we're exactly at time. This has been a very fruitful conversation, and thank you to Lori and Susan for joining us. Have a good day.
Thank you.